So hello, good morning, good afternoon and good evening to all our speakers, shares and our audience in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from Italy, Professor Cecilia Casali. Prof. Casali is the head of Brain Metastasis Unit and Deputy Chief of Neuro-oncological Division at the Fondazione IRCCS Istituto Neurologico Carlo Besta, Milan, Italy. With over 2 decades of clinical and academic experience in neurosurgical oncology, she has dedicated her career to the advancement of surgical techniques for brain tumors, the integration of operative imaging, particularly ultrasound, and the application of innovative technologies such as LIT and robotic assisted navigation. Her current focus lies in the management of brain metastasis and translation research in mechanobiology through projects such as MetaMech Master Protocol in collaboration with the IOFM, and she is deeply committed to training the next generation of neurosurgeon and to fostering multidisciplinary collaboration in the treatment of complex cranial pathologies. We are extremely honored and grateful to her for accepting our invitation to be a speaker for today's webinar, and today she will be talking about surgical management of brain metastasis, redefining the role of resection in the era of radiosurgery and targeted therapies. The speaker for the second session of today is our very honorable guest from China, Professor Chao. Professor Chao is the Deputy Chief Physician of Neurosurgery in the Peking University Third Hospital, China. He is also the Deputy Head of Spinal Cord and Minimally Invasive Spine Specialty and Deputy Head Neuroregulation Specialty. His clinical interests are focused on intelligent minimally invasive techniques in neurosurgery, spinal cord and spinal nerve surgery, and neuroregulation technologies. He is an expert at DVS, VNS, SCS, intrathecal drug delivery system, and peripheral nerve stimulation. We are extremely honored to have him today with us as speaker for our webinars, and today he will be sharing his experience about the applications of neuroregulation techniques in the reconstruction of neural function after neural injury. The chair for the first session of today is our honorable faculty from Japan, Professor Akitake Mukasa. Prof. Mukasa is the professor and chairman in the Department of Neurosurgery at the Graduate School of Medical Sciences, Kumamoto University, Japan. His clinical interests are focused upon neuro-oncology, treatment of malignant brain tumors and image-guided surgeries, awake surgeries, molecular genetics, and biology of brain tumors. He is an integral part of the Japan Neurosurgical Society and Japan Board of Cancer Therapy, and he has been rewarded with several awards and honors for his outstanding contribution towards neurosurgery. He is also a noted author with several publications in various peer-reviewed journals, and we are extremely honored to have him today to chair the session of Professor Casali. The chair for the second session of today's webinar is our honorable guest from Nepal, Professor Amit Thapa. Prof. Thapa is the professor and head of Department of Neurosurgery at the Kathmandu Medical College Teaching Hospital, Sinamangal, Kathmandu, Nepal. He is the Vice President of the Nepali Society of Neurosurgeons and Vice President of the Nepalese Epilepsy Society, and past chairperson and founding treasurer of the Neurospine chapter of NESON, and past editor-in-chief of the Nepal Journal of Neurosciences. He is a noted author who has published several articles in various peer-reviewed journals. We are extremely grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues from China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Libun Singh from Malaysia is my co-host for today, and with that introduction, I would like to hand over this online podium to our first chair, Professor Akitake Mukasa.
Thank you very much for kind introduction, Raja. So good afternoon, good everybody, good evening, everybody. So my name is Akitake Mukasa from the Department of Neurosurgery at Kumamoto University Hospital in Japan. So my main clinical research specialty is malignant brain tumor, including brain metastasis. So it is my pleasure to chair this session and to introduce the first lecture today by Professor Cecilia Casali from Milan, Italy. So title of the first topic is surgical management of brain mets regarding the role of resection in the era of radiosurgery and targeted therapies. So as you all know, the treatment of brain metastasis has changed greatly in recent years. So radiation therapy has progressed, and now therapeutic radiosurgery is widely used instead of whole radiation therapy. So as a result, brain mets can be treated effectively with few side effects, even in patients with long-term survival. At the same time, the systemic therapies such as molecular targeted therapies and immunotherapy has also improved, especially for cancer like lung cancer, melanoma, and breast cancers. Because of these advances, the role of surgical resection is also changing. I think this does not mean that surgery is becoming less important. Rather, I think that surgery now has a new role in combination with radiosurgery and modern drug therapies. So today, we are very honored to learn about the current and the future role of surgery for brain metastasis from Professor Casali. So, Professor Casali, are you ready? Please start your lecture.
Thank you, Prof. Mukasa. Thank you. It's a really great pleasure to address such a group of distinguished colleagues. So let's start my presentation. So good afternoon. Thank you. Thank you to everyone. Before starting my presentation, I'd like to sincerely thank Professor Yoko Kato and Dr. Raja for the kind invitation and for giving me the opportunity to participate in this ACNS webinar. It's a pleasure and an honor to be part of an initiative of such high scientific impact, which continues to promote excellence and collaboration within the global neurosurgical community. Today, I will discuss the surgical management of multiple brain mets, redefining the role of resection in the era of neurosurgery and targeted therapies, focusing on how the role of resection is evolving in this era. This topic reflects a real shift in neuro-oncology. Surgery is no longer judged simply by how much tumor we remove, but by how effectively it enables multidisciplinary care. The goal of this talk are fourfold. First, to reassess the role of surgery in patients with multiple brain mets, moving beyond numerical cutoff. Second, to identify evidence-based indication for resection, particularly in complex intracranial disease. Third, to explain how surgery integrates with SRS and modern systemic therapies rather than competing with them. And finally, to highlight how surgical decision-making directly influences neurological function, quality of life, and access to oncological treatment. This slide summarizes the forces that are fundamentally changing how we think about metastatic disease. What is illustrated here comes from recent precision medicine data showing that patients with advanced treatment-refractory cancer are now living significantly longer when effective targeted therapies can be delivered. In the study from which this figure is taken, patients who were able to receive matched targeted treatment had a median overall survival of approximately 15 months, compared with about 6 months in patients who did not receive targeted therapy, despite having similar baseline clinical main characteristics. This is a crucial point. Survival is no longer determined solely by tumor burden or number of metastatic sites, but increasingly by the ability to access effective systemic treatment. As a result, many patients now live long enough to experience metastatic disease as a chronic condition, rather than a rapidly terminal phase. At the same time, local therapy have evolved. Stereotactic radiosurgery has expanded well beyond the oligometastatic setting and is now routinely used in patients with multiple brain mets, offering durable local control with limited neurocognitive toxicity. Importantly, systemic therapies, in particular targeted agents and immunotherapy, now show documented intracranial activity, but only in patients that are neurological stable and able to continue treatment. In the precision medicine cohort shown here, patients with fewer metastatic sites and preserved performance status were more likely to benefit, reinforcing the importance of maintaining functional reserve. Taken together, these developments mean that the historical paradigm, surgery for one lesion, radiation for many, is no longer sufficient. Instead, we are moving toward a model in which local and systemic therapies must be strategically combined, with surgery playing a role not based on lesion count, but on its capacity to restore function, reduce disease burden, and enable life-prolonging systemic treatment. This shifts to the foundation for rethinking the role of surgery in patients with multiple brain mets. As emphasized in the recent review by Mansouri and colleagues, advanced in immune checkpoint inhibitors and brain penetrant targeted therapies have substantially prolonged overall survival across multiple tumor types, including melanoma, non-small cell lung cancer, and breast cancer. Importantly, these therapies have not only improved extracranial disease control, but have also demonstrated meaningful intracranial activity, which was largely absent in early systemic treatments. However, this graph also highlights a critical and somewhat paradoxical consequence of this progress. As systemic disease is controlled more effectively and patients live longer, the brain increasingly becomes a limiting site of progression. Mansouri et al. Clearly describe how improvement in overall survival have led to a rising incidence and prevalence of brain mets, not because treatments are failing, but because patients now survive long enough for intracranial disease to emerge and progress. In this setting, the brain function as a sanctuary site where large symptomatic or rapidly progressive metastases can compromise neurological function even while extracranial disease remains stable or responding. Although modern systemic therapies can induce intracranial responses, their efficacy is often insufficient for bulky lesions and critically depends on patient remaining or neurological stable and able to avoid prolonged corticosteroid use. This is the key message underlying these curves. Longer survival exposes the brain as a bottleneck in disease control. Neurological deterioration rather than systemic progression increasingly becomes the factor that limits continuation of effective oncological therapy. For this reason, local therapies, including stereotactic radiosurgery and surgery, have regained relevance, not despite systemic advances, but because of them. And as Mansouri et al. Colleagues stress, optimal management of brain met now requires a multidisciplinary strategy aimed at preventing neurological decline while allowing systemic therapy to continue uninterrupted. Within this framework, surgery assumes a strategic role by rapidly relieving mass effort, improving neurological function, and reducing steroid dependence. Surgical resection can preserve the survival benefit achieved by modern systemic therapies, directly influencing the survival trajectories represented in these curves. In other words, these survival curves do not argue against local intervention. Instead, they underscore the necessity of integrated local and systemic treatment, where surgery is selectively used to sustain long-term disease control and quality of life. This slide illustrates the EANO guidelines and how they have fundamentally reframed the decision-making in patients with brain met. Rather than starting from the number of metastases, the EAN algorithm begins with a clinical and functional assessment of the patient. The first key step is the evaluation of the performance status, neurological symptoms, and systemic disease control. This already represents a major paradigm shift. Treatment selection is no longer driven by lesion count, but by patient condition and therapeutic goals. From this point, the flowchart emphasizes the importance of identifying symptomatic or dominant lesion. We'll discuss after the meaning of dominant lesion. But now, in patients with neurological symptoms, significant mass effect or lesions causing hydrocephalus, the EANO guidelines clearly indicate that local treatment is required. regardless of whether the patient has one or multiple brain mets. Importantly, when a dominant lesion is present, the algorithm explicitly integrates surgical resection as a key option, particularly when rapid symptom relief, tissue diagnosis, or steroid reduction is needed. Surgery is therefore positioned early in the decision pathway, not as an exception, but as a strategic intervention. Only after addressing dominant or symptomatic disease does the flowchart move towards stereotactic radiosurgery or whole brain radiotherapy, depending on the lesion size, number, prior treatments, and expected neurocognitive impact. The sequence 6 reinforces the concept that surgery and radiation are complementary rather than competing modalities. Another crucial aspect highlighted in this flowchart is the integration of systemic therapy. The algorithm explicitly accounts for tumor biology, availability of targeted agents or immunotherapy, and the need to maintain neurological function in order to continue effective systemic treatment. Overall, this flowchart captures the essence of the changing paradigm. Management of brain met is no longer linear number-based, but multidimensional and individualized. Surgery, radiosurgery, radiotherapy, and systemic therapy are selected and sequenced based on functional impact, dominant disease, and therapeutic opportunity rather than rigid historical rules. This framework provides the conceptual foundation for reevaluating the role of surgery in patients with multiple brain mets. So why surgery still matters? Despite major advances in stereotactic radiosurgery and systemic therapy, surgery continues to play a critical and irreplaceable role in management of brain met. First, surgery provides immediate relief of mass effect. As emphasized by our Soyan colleague, a substantial proportion of patients undergoing surgery harbor large space-occupying lesions, often exceeding the volume suitable for single-fraction radiosurgery. In these cases, resection is the most effective way to rapidly reduce intracranial pressure, prevent neurological deterioration, and manage life-threatening complications such as hydrocephalus or brainstem compression. Second, surgery allows rapid neurological improvement and preservation of functional status. One of the most important findings in this study is that postoperative KPS, rather than the extent of resection, is the strongest predictor of overall survival. Most patients either maintained or improved their functional status after surgery, which is crucial because neurological function that directly determines whether a patient can receive postoperative radiotherapy or systemic treatment. Third, surgery enables continuation of oncological therapy. The data clearly show that patients who were unable to receive postoperative radiotherapy or systemic therapy had dramatically worse survival. Surgery therefore matters not because it maximizes site reduction at all costs, but because it helps patients remain eligible for life-prolonging adjuvant treatments. Fourth, surgery provides tissue for histological and molecular analysis. In the ERSOI cohort, more than 20% of surgery were performed at least in part to obtain tissue for molecular profiling. In the era of targeted therapies and precision oncology, tissue acquisition has become a major indication for surgery, particularly in cases with unknown primary tumors, atypical imaging, or the need to guide targeted or immune-based treatments, as in melanoma. Finally, surgery should be understood as a strategic intervention rather than a purely cytoreductive one. The study shows that small residual tumor volumes do not necessarily compromise survival, whereas major surgical complications and postoperative neurological deficits have a profound negative impact on outcome. This reinforces the concept that the goal of surgery is not maximal resection at any cost, but maximal functional benefit with minimal morbidity. Taken together, the stats support a modern view of surgery. It remains essential not because it replaces other treatments, but because it preserves neurological function, enables multidisciplinary care, and allows patients to fully benefit from advances in radiation and systemic therapy. The clinical factors, also called GPA. As we all know very well, patient selection is the most critical step in determining whether surgery will be beneficial. The prognostic assessment developed by Sperduto et al. In 2020, now updated diagnosis-specific graded, so-called GPA, provides one of the most robust frameworks we have for understating prognosis in patients with brain met. What this work clearly demonstrates is that survival varies widely, and this variability is driven primarily by clinical factors rather than by treatment modality alone. Of course, the first and most important factor is performance status, particularly the Karnofsky performance status. Across all tumor types, KPS is the strongest and most consistent predictor of survival, as we all know. Patients with a KPS of 70 or higher have substantially longer median survival, often exceeding 1 year, whereas patients with a KPS below 60 have very limited life expectancy. This is why most guidelines and the GPA itself use a KPS higher than 70 as a practical threshold for considering aggressive local treatment, including surgery. The second key factor is systemic disease status. The presence of uncontrolled extracranial metastasis is associated with significantly worse outcome, while patients with absent or controllable systemic disease can experience prolonged survival. Importantly, the GPA incorporates extracranial disease status across multiple histologies, reinforcing the idea that surgery is most meaningful when it contributes to overall disease control and not just intracranial palliation. Life expectancy is the natural consequence of these factors. The GPA data show that median survival can range from only a few months to more than 3 years, depending on diagnosis, molecular profile, and clinical condition. In practical terms, this supports a commonly used threshold of the expected survival of at least 3 to 6 months when considering surgery, while also reminding us that many patients exceed this estimate when appropriately selected. Another essential element is the ability to resume systemic therapy. The GPA framework highlights that patients who maintain functional independence are far more likely to receive postoperative radiotherapy or systemic treatment, which strongly influences survival. Surgery should therefore be offered only when it's expected to preserve or improve neurological function rather than compromise it. Taken together, this data reinforce a central principle. Surgery must change the neurological and therapeutic trajectory of the patient. When performance status is adequate, systemic disease is controllable, and surgery allows continuation of effective oncological therapy, resection can play a decisive role, even in patients with multiple brain metastases. The intracranial factors. Once clinical eligibility has been established, the next step is patient selection, focuses on intracranial disease characteristic. In many cases, these factors are actually more decisive than systemic disease when considering surgery. The first and most important element is the presence of a dominant symptomatic lesion. This refers to a metastasis that is responsible to neurological symptom, functional decline, or radiological mastectomy. Even in patients with multiple brain met, symptoms are often driven by one lesion. This means that addressing that lesion surgically can dramatically change the patient's clinical course. Lesion size is another critical factor. Metastases larger than 3 centimeters are less suitable for stereotactic radiosurgery alone due to reduced local contour or increased risk of radiation necrosis. In these cases, surgery offers more reliable and immediate decompression. Closely related to size is the presence of significant peritumoral edema or midline shift. Edema-related mass effect is a major cause of neurological deterioration and steroid dependence. Surgical resection directly addresses both the tumor and the surrounding edema, often allowing rapid neurological improvement and steroid tapering. The hemorrhagic metastases represent another clear indication for surgery. This lesion frequently cause acute neurological decline and are less predictable in their response to radiation. Surgical evacuation not only relieves mass effect, but also prevents further bleeding or diagnostic uncertainty. Refractory seizures are also an important consideration. When seizures persist despite optimized medical therapy and are associated with a surgical accessible lesion, resection can provide effective symptom control and significantly improve quality of life. Finally, surgery should be considered when lesions are poor candidates for stereotactic radiosurgery due to size, location, prior radiation, or proximity to critical structures. The key concept underlying all these factors is this: the number of brain met by itself is not the contraindication to surgery. Instead, surgical decision-making should be guided by which lesion matters most, how it affects neurological function, and whether its removal can improve the patient's ability to continue multidisciplinary treatment. This leads directly to the next concept, which is central to modern surgical strategy, the definition of the dominant lesion. The concept of dominant lesion is central to modern surgical decision-making in patients with multiple brain met. Importantly, the dominant lesion is not necessarily the lesion with the largest diameter, nor is defined by the radiological appearance alone. Rather, it's the metastasis that most strongly influences the patient's neurological condition and treatment trajectory. In many cases, the dominant lesion is the one responsible for clinical symptoms. This may include focal neurological deficits, increased intracranial pressure, cognitive decline, reduced level of consciousness, or seizures. Even when multiple metastases are present, symptoms are often driven by a single lesion. The dominant lesion may also be the one causing significant mass effect or hydrocephalus. Lesions that distort normal anatomy, compress eloquent structures, or obstruct cerebrospinal fluid pathways can rapidly deteriorate neurological function and require prompt intervention, as the lesion situated in posterior fossa. In another situation, the dominant lesion is the one that limits or prevents systemic therapy. Large lesions associated with extensive edema often necessitates of high-dose corticosteroids, which can compromise the efficacy of immunotherapy and delay oncological treatment. In these cases, surgical removal of the dominant lesion can restore eligibility for systemic therapy. Finally, the dominant lesion may be the largest lesion, particularly when size correlates with mass effect, hemorrhage, or poor response to stereotactic radiosurgery. The key point is that dominance is defined by clinical impact rather than lesion count. Identifying the dominant lesion allows us to adopt a focused surgical strategy. By addressing a single high-impact metastasis, we can often achieve meaningful neurological improvement even when other lesions remain. The concept underpins the shift from number-based treatment algorithms to function-oriented, patient-centered surgical planning, and directly informs the surgical strategies discussed in the next slide. Surgical strategies. Once a dominant lesion has been identified, the question is no longer whether to operate, but how to integrate surgery into a multimodal strategy. The contemporary approach to surgery in patients with multiple brain mets is selective and goal-oriented rather than purely cytoreductive. As shown in the large modern series by Bander and colleagues, surgery is most often employed in patients with fewer, larger, and symptomatic metastases, particularly when rapid neurological stabilization is required. The first strategy is targeted resection of the dominant lesion. This involves removing the lesion responsible for symptom, mycethed, or steroid dependence, while leaving smaller or asymptomatic metastases to be treated by stereotactic radiosurgery or systemic therapy. Importantly, the study shows that the extent of resection is less important than postoperative functional status, reinforcing that surgical goals should prioritize neurological preservation. A second key strategy is surgery as an enabling intervention. Bander et al. Demonstrates that the patients who were able to receive postoperative radiotherapy or systemic therapy had significantly better survival, while those who could not have very poor outcomes. Surgery therefore matters not as a standalone treatment, but because it allows patients to continue life-prolonging oncological therapy. Another important approach is surgery for larger hemorrhagic metastases. Hemorrhage and lesion size were strong predictors of surgical selection in the cohort. These lesions are often poor candidates for stereotactic surgery and can cause rapid neurological decline. Surgical evacuation provides immediate decompression and diagnostic clarity. Surgery also plays a role in complex anatomical situations, such as lesion causing hydrocephalus or obstructing cerebrospinal fluid pathways, where a section or CSF diversion may be required as part of the initial strategy. Crucially, this paper reinforces that surgery should be performed within a multidisciplinary framework. The best outcomes were observed when surgery was integrated with stereotactic surgery and modern systemic treatments, rather than using isolation. The overreaching message is that modern surgical strategies not remove everything, but rather remove what matters most at the right time, in the right patient, to preserve neurological function and maximize access to the multimodal therapy. This approach explains why surgery continues to show an association with improved survival in carefully selected patients, even in the era of immunotherapy and precision medicine. The concept of multiple surgical resection in patients with brain mets remains controversial, but it's no longer considered categorically inappropriate. The key principle is that multiple resection should never be routine. They should be considered only in highly selected patients when the expected neurological and therapeutic benefit clearly outweighs the surgical risk. First, lesion accessibility is critical. Multiple resection may be reasonable when metastases are superficial, located in non-eloquent areas, or clustered within the same hemisphere, allowing safe exposure through a limited number of surgical corridors. Second, operative time and surgical burden must remain acceptable. Prolonged anesthesia, excessive brain manipulation, or increased risk of postoperative complication can negate any potential benefit. The goal is neurological preservation, not maximal cytoreduction. Third, patient-related factors are essential. Candidates should have good performance status, controlled or controllable systemic disease, and the realistic likelihood of resuming adjuvant therapies after surgery. Fourth, multiple resection should only be undertaken in the setting of an experienced neurosurgical team, where advanced neuronavigation, interperipheral monitoring, and multidisciplinary coordination are available. Most importantly, the rationale of multiple resection must remain function-oriented. The aim is to address more than one lesion only when each contributes meaningfully to neurological symptoms or treatment limitation. In this context, the multiple resections are not standard practice, but they are not forbidden. They represent an extension of the nominal lesion concept in very carefully selected cases, and they underscore the broader shift toward individualized, patient-centered surgical strategies. In this slide, I'm focusing on the surgical debate between en bloc and piecemeal resection for brain metastasis. In general, piecemeal resection means internal debulking first, followed by capsule removal, and it's traditionally used because it can reduce traction and facilitate removal in difficult location. However, several studies suggest that this approach may be associated with a higher risk of tumor cell spillage, potentially leading to local recurrence and especially leptomeningeal dissemination. On the other hand, en bloc resection aims to remove the metastasis as a single piece by dissecting along the tumor-brain interface, minimizing exposure of the tumor or the tumor core to the surrounding cerebrospinal fluid spaces. This technique is increasingly considered as an oncological strategy in brain met surgery. Importantly, the ASTRO guideline recognizes surgery as an effective option in selected patients, but it also highlights that, based on current evidence, no formal recommendation can be made regarding the preferred method of resection because the overall level of evidence remains low. Still, retrospective clinical data suggest a potential advantage of en bloc resection when feasible. For example, reviews of surgical series report lower rates of leptomeningeal disease after en bloc resection compared with piecemeal techniques. A recent literature review also supports this concept, suggesting that en bloc resection, when technically achievable, may be associated with a lower risk of leptomeningeal spread, lower local recurrence, possibly less intraoperative bleeding, and fewer perioperative complications while preserving a normal anatomy. However, en bloc resection is not always feasible. Large tumors, deep lesions, proximity to eloquent cortex, or cystic consistency may still require piecemeal strategy in order to maintain safety and avoid neurological morbidity. So overall, the takeaway is that en bloc resection should be considered the preferred technique when feasible and safe, especially for small, superficial, well-demarcated metastases, while piecemeal resection remains necessary in complex or high-risk anatomical scenarios. Now I'd like to focus on postoperative SRS or cavity SRS, which has become a key strategy to improve local control after resection while avoiding the neurocognitive toxicity of whole brain radiotherapy. A pivotal phase 3 randomized trial for MD Anderson compared postoperative cavity SRS versus observation after complete resection of 1 to 3 brain met. The Kaplan-Meier curves clearly separate early. At 12 months, freedom from local recurrence was 72% with SRS versus 43% with observation, with a hazard ratio of 0.46, statistically significant. So the main message is that surgery alone is not enough to guarantee the durable local control, and SRS provides a meaningful benefit at the surgical bed. However, when we look beyond local control, the overall intracranial disease burden remains a challenge. This is why a second crucial question is whether postoperative SRS can replace whole brain therapy as a standard adjuvant strategy. In the multicenter randomized phase 3 trial performed by Brown et al., published in Lancet, postoperative SRS to the cavity was directly compared with whole brain radiotherapy. The Kaplan-Meier analysis showed that the cognitive deterioration-free survival was significantly longer with SRS, with a median of 3.7 months versus 3.0 months with whole brain therapy, with an HR of 0.47. At 6 months, among evaluable patients, of course, cognitive deterioration occurred in 52% after SRS versus 85% after whole brain therapy, confirming a strong neurocognitive advantage for local treatment. Importantly, despite these differences, the overall survival curves were essentially overlapping. Median survival was 12.2 months for SRS versus 11.6 months for whole brain therapy, with no significant difference. So postoperative SRS preserve cognitive functions without compromising survival, even though whole brain therapy provides better global intracranial control. And this concept is consistent with early randomized evidence in the non-surgical setting, where SRS alone was associated with less cognitive decline compared with SRS plus whole brain radiotherapy, again without a survival benefit from adding whole brain radiotherapy. So overall, the take-home message is postoperative SRS has strong level 1 evidence showing better local control compared with observation, and better cognitive outcomes compared with whole brain radiotherapy, making it a modern standard of care after metastasis resection in selected patients. Now I'd like to move to an emerging paradigm, preoperative stereotactic radiosurgery, also called neoadjuvant SRS. The rationale is very practical. Instead of targeting a postoperative cavity, often irregular, dynamic, and requiring margins, preoperative SRS treats the intact metastasis, which is clearly visible on MRI with no additional margin, meaning ZTV equals PTV. This potentially reduces dose to healthy brain and may lower toxicity. One of the most relevant updated clinical series is from Prabhu and colleagues, including 117 patients and 125 lesions treated with single fraction preoperative SRS, followed by surgery typically within 48 hours. The median interval was 2 days. They used the dose reduction strategy of only 10 to 20% compared with standard SRS dosing, with a median dose of 15 gray. In terms of oncological outcomes, their 2-year cumulative incidence was cavity local recurrence, 25.1%, leptomeningeal disease, 4.3%, symptomatic radiation necrosis, 4.8%. So overall, it showed excellent cavity control with very low rates of both cell MND and symptomatic RM. And key message from this study is also patient selection. Subtotal resection was a strong negative prognostic factor. In fact, STR was associated with a significantly higher risk of local recurrence and worse survival, suggesting that preoperative SRS works best when a gross total resection is expected. Then, looking at comparative data, Patel and colleagues performed a multi-institutional analysis comparing preoperative SRS versus postoperative whole brain therapy in resectable brain metastases. They found that outcomes were very similar between cohorts, with 2-year local recurrence around 25% in both groups, and the low rate of leptomeningeal disease, again 3.5 with pre-op SRS and versus 9% with post-op whole brain therapy, without statistically significant differences. Importantly, overall survival was also comparable, with a median overall survival of around 13 months, reinforcing that preoperative SRS can be a reasonable alternative strategy in selected patients. So the main takeaway is that preoperative SRS offers potential advantages over postoperative cavity SRS. Smaller treated volume with no cavity expansion, less contouring uncertainty, better compliance because radiation is delivered before recovery, and potentially reduce leptomeningeal dissemination by sterilizing tumor cells prior to surgical manipulation. In summary, preoperative SRS appears feasible, safe, and oncologically effective, and it's increasingly considered a modern strategy, especially when gross total resection is planned. So now we will move to preoperative stereotactic radiosurgery. Is an emerging, we talk about this, is an emerging strategy in the multimodal management of resectable brain met. The main rationale is that instead of irradiating this cavity, we just can be irregular. The preoperative SRS target the intact tumor, which is clearly defined on preoperative MRI. Overall, preoperative SRS is increasingly considered a rational and technically elegant alternative to postoperative cavity, especially in patients with well-demarcated resectable lesions where gross total resection is expected. Sorry, I just come back with this slide. Okay. So in the slide, I'm showing the clinical outcomes from Patel and colleagues focusing on the Kaplan-Meier curves. This multi-institutional analysis compares preoperative SRS followed by resection versus a more traditional strategy of postoperative whole brain radiotherapy after resection. If we look at the local control curves, as we can see, the key message is the local control remains solid in both groups, and the curves stay relatively close over time, suggesting that preoperative SRS can achieve local outcomes comparable to postoperative whole brain therapy. Similarly, when we look at the curves related to intracranial control and survival, the important finding is that overall survival is not significantly different between the two approaches, reinforcing that the concept that preoperative SRS is not compromising oncological outcomes while allowing us to avoid whole brain associated neurotoxicity. So the way I interpret this Kaplan-Meier plot is that preoperative SRS appears to be a safe and effective strategy with comparable control and survival, and with a strong theoretical advantage in reducing unnecessary irradiation of normal brain compared with whole brain therapy. In summary, these data support preoperative SRS as a modern approach that can preserve oncological efficacy. Immunotherapy. Now, I'd like to shift from local therapies to the systemic revolution, focusing on the interaction between stereotactic, radiosurgery, and immunotherapy, especially immune checkpoint inhibitors. A key clinical question is whether adding ICIS to SRS improves intracranial response and survival, and whether this combination increases toxicity, particularly radiation necrosis. In non-small cell lung cancer, Singh and colleagues reviewed 85 non-small lung cancer patients treated with gamma-knife SRS, comparing with the anti-PD-1 group versus a chemotherapy group. Interestingly, median survival was not significantly different, about 10 months with immunotherapy versus 11.6 months with chemotherapy. So unlike melanoma, the survival advantage of immunotherapy does not automatically translate into a clear intracranial survival benefit in this retrospective radiosurgical cohort. However, when they look at the volumetric response, they found something clinically relevant. In larger lesion greater than 500 millimeters, the combination of SRS plus immunotherapy led to higher proportion of shrinking lesions compared with chemotherapy, and also a faster initial response. So, in selected bulky metastases or lesions near eloquented structures, immunotherapy may still add value by accelerating response kinetics. Toxicity is always the other side of the coin. A large international multi-center study by Lehrer and colleagues in melanoma included 203 patients with 1,388 metastases and compared concurrent versus non-concurrent administration of ICIS and SRS. They found that symptomatic radiation necrosis rates were very similar, 9.4 in the concurrent group and 8.2 in the non-concurrent group, with no significant difference. Most importantly, on multivariable analysis, the key drivers of symptomatic were less than 10 and BRAF mutation status, while timing of ICIS relative to SRS was not associated with increased RM risk. So overall, the take-home message is that SRS plus immunotherapy is feasible and generally well tolerated, and toxicity risk seems more related to dose volume in parameters and tumor biology than the simple choice of giving ICIS concurrently. So, Continuing on systemic therapy integration, this slide highlights two important clinical concepts: target therapy interactions and the modern interpretation of post-treatment imaging changes. In the context of targeted therapies, especially in melanoma, this increasing awareness that biology matters. In the multi-center study, BRAF mutation was associated with a significantly higher risk of symptomatic radiation necrosis after SRS combined with ICIS. So in these patients, planning becomes even more important, because particularly in terms of limiting the irradiated brain volume. A second key concept that is not every post-SRS enhancing lesion is true tumor progression or classic radiation necrosis. In a very large international core study of 700 patients with 5,000 metastases, Larry and colleagues analyzed treatment-related imaging changes, so-called TRICs, often labeled as imaging-defined necrosis. They found that TRICs in about 10% patients, and most were mild. Around 16% were asymptomatic and managed with observation only. What is really interesting that TRICs were not only a toxicity marker, but also correlated with outcomes. On multivariable analysis, the presence of TRICs was associated with improved overall survival, with a hazard ratio around 0.66 and a median overall survival of 29 months versus 23.1 months in patients without TRICs. In other words, in selected cases, TRICs may reflect an effective inflammatory or immune response rather than simply treatment damage. Finally, their analysis confirmed again the importance of radiosurgical parameters. So the practically message from this data is, when combining SRS with modern systemic therapies, immunotherapies, or targeted agents, we should optimize radiosurgery, interpret the imaging changes carefully, and avoid overtreating pseudo-progression-like patterns with premature salvage intervention. So, to conclude, I think that the key message is that surgery remains essential, but only in selection patients, not because we need to remove more tumor, but because we need to remove the lesions that is truly driving symptoms, mass effect, steroid dependence, or diagnostic uncertainty. In this modern setting, indication for surgery are functional and strategic. The goal is to restore neurological stability, protect performance status, and keep patients eligible for the therapies that actually prolong survival. That is why integration with the stereotactic radiosurgery and systemic treatment is mandatory. Surgery should never be viewed as a standalone option. It's a part of a sequence where resection enables SRS to the cavity or remaining lesions and allows immunotherapy or targeted agents to continue without interruption. And ultimately, this is where neurosurgeons remain central decision makers. We are not just operating, we are helping define the treatment trajectory by identifying the dominant lesion, choosing the safest oncological strategy, and coordinating timing, radiation, oncology, and medical oncology to maximize both survival and quality of life. So thank you for your attention.
Thank you very much for the Professor Casali for your very comprehensive and excellent talk. So I clearly understand your message that the number of metastases is not the indication of surgery anymore, and then we have to find the right patient to be operated. So now we are open for the questions. So anybody has...
There are 4 questions on the chat box. Can you see that?
Oh, okay. So the first question is that in the case of multiple intracranial cystic metastasis, if there is an increase in size of cystic metastasis after resection of one metastasis sufficient to cause neurological deterioration, is secondary surgery advisable?
As we have said, we have to just evaluate the patient. Is it safe? We can do that. Is it useful for the patient? Yes, we can repeat surgery. It's not useful, we don't repeat surgery. I think it's not so easy, but could be easy if you just ask this. And we have to always have a multidisciplinary approach. We have to always talk with the oncologist. which is the life expectancy. We have to talk about all these things while deciding what to do. You know, we are a surgeon, so we like to operate, and we can operate everything, but you have to be worth of it. Yeah. So we can do that, but you have to evaluate it.
Okay, thank you. I agree your opinion. So, and next question is also kind of difficult one. If there is a need for a decompressive craniotomy, craniectomy intraoperatively despite corticosteroid use, what would be the next course of management for the patients in case the patient has multiple intracranial mets that may need adjuvant radiotherapy, as it would delay the timing of radiotherapy?
I need to understand. He has performed craniectomy, the compressive craniectomy. Yeah, I do not perform the compressive craniectomy in patient with multiple brain metastases. I think it's not useful. I think it's in the phase of the disease, final phase of disease. I don't think it can be useful, and so that's why I really don't perform it. Because why I do perform it? Because there are too many metastases. I can bear them. Yeah. So I do not perform it.
I see. I understand. So
sometimes you have to say no.
Okay, I understand. So, and the next question is, how soon after surgery for the dominant lesion do we administer the patient the SRS? In case of multiple metastasis, does the bed of resected dominant lesion need radiation too, if totally resected?
Yeah. Yeah.
Yes.
We need 1 month. 1 month you can usually they wait just they repeat the MRI in 3 weeks to understand how the surgical cavity has moved, but they perform SRS on the surgical cavity and also on the other lesions. Yeah.
And the last question here is, how do you approach multiple mets with larger accessible lesion causing
raised intracranial hypertension, and after surgery of single lesion and adjuvant therapy it recurs, then what would you suggest?
I think we have to better understand which is the better thing we can do. He has a larger lesion that is the cause of the symptoms. The intracranial pressure, you can manage it with removing the lesion, using pharmacologic therapy, drug therapy, and you have to better understand which is the best thing to do. The key point is to understand that the metastatic patient is not only a patient with brain lesion. The metastatic patient is a whole body patient that we have to manage, taking in account so many things. Also in its other therapy, we just have to prolongate life for 2 weeks. Is it good? No. I think that we have to understand which is the best thing to do for this particular patient, because it's a metastatic patient. It's not a glioma. It's not a vascular malformation. It's a metastatic patient, and sometimes the systemic disease is worse than the brain disease. So we have to take in account too many things. I don't have one response, but I think that we have to multidisciplinary treat these patients. If I operate them, they can have another kind of therapy. They can do something else. I'm just saving a life. I'm just doing what? one of the most bigger problem in our institution is in the leptomeningeal dissemination with the hydrocephalus. Do you operate them for the, do you put the DVP or not? The shunt or not? It's a very, very hard question, because they are dying in about 1 month, 2 months. So do you put the shunt or not put the shunt? It's not easy to understand, but just the shunt. I don't operate a bigger lesion in the disseminated patient. Maybe you can take this in account, which kind of surgery you can propose is the easier one and the better one for that patient.
I totally agree with your opinion. So this may be related to next question, that is in what situation can excision of metastasis being done without controlling the primary lesion? Do you understand?
Yeah. I think that you have to take in account the surviving rate, the weighted surviving rate, and if it's useful for the neurological status of the patient. I think that one of the argument, most treated argument, is the posterior fossa tumors. Maybe the patient can have just 6 months weighted of the supremacy, survival, but often they are big, very, very big, very debilitating, and so useful. I operate them just to save a life.
Yes. Yeah, I think that GPS scoring is also useful to determine how
we have to use it. Yeah. And sometimes we just forget it.
Okay.
Yeah.
My question is that, as you said, that multidisciplinary discussion is very important for this field. So, but it's sometimes difficult that to collect many specialists to discuss the patients. So how do you organize in your institute the multidisciplinary team in the practice?
We have a metastasis board about every week. So we try to manage this patient, discussing with the radiologist, the oncologist, and the surgeon and the surgeons. So we try to do it every week, not every week, but we try to do it. But when we have something very most urgent, we just call for another reunion teams or something like that. Yeah.
Okay, sounds great.
Yeah.
Other questions from the panelist?
Prof. Thapa has raised his hand. Prof. Thapa?
Oh.
Yeah, thank you, Dr. Casali. It was a wonderful presentation, very comprehensive. You started with post-operative SRS as a modality to be considered in induction to the surgery, and then you moved to the pre-operative SRS, and then you also talked about the targeted and immunotherapies. Throughout your lecture, I was very much impressed that the references which you were using were 2020 onward, particularly for post-operative SRS, and there were a few references which were as recent as 2025. But when you talked about pre-operative SRS, the only literature which was being quoted was 2016. So do you think that in the light of immunotherapies and targeted therapies which are upcoming and has given a sort of a paradigm shift in many of the approaches which we are doing for the brain tumors, not even metastasis, but also for the primary tumors here these days. Do you think that the preoperative SRS can be merged with the immunotherapy and targeted therapies, and we can have another protocol in near future?
I think so. We are actually, we have a study about the preoperative MRI alone and preoperative MRI with immunotherapy. But, you know, it's the most difficult thing is that you have to make difference between one histology and another histology. It's not easy to have big numbers to make the difference. So we need multi-center study, and if you are interested in, I can share our program, because I think could be very, very interesting. Yeah, we're trying to, there's a lot of study that we are participating on in this in this field, because I think it will be the future.
That's very true, because because now many groups are now professing for a biopsy-first approach, even with a well-proven diagnosis of a metastasis earlier. So this is now coming up, particularly in light of immunotherapy and targeted therapies, which is upcoming. Yeah.
Thank you very much. Any questions from Liu Bun Singh, my co-host?
Thanks, Raja. Thanks, Professor Casali. Very comprehensive talk on metastatic. I like your last point of discussion regarding how guideline failures. I would like to bring out your attention to Karnofsky performance score, which was formulated for me. I think it's mainly look at the functional status for patient with extracranial or extra CNS tumor. And then we look at overall functional status. However, when we decide to treat brain metastatic, we still use the same. I'll give you an example: a patient with well-controlled lung CA with single mets near to the motor strip, we definitely bring the KPS below 70. So, are we going to treat them? So, I still feel that using Karnofsky performance score in determine a treatment or not treatment for brain metastatic may not be so accurate. I need your opinion for that. Secondly, regarding neoadjuvant and adjuvant SRS, how do you decide how many times can you treat for new lesion? I mean, we are treating what we can see now. Subsequently, if patient develop new lesion, how do we decide? What is the limit? And what do you think that the role of IORT for brain metastatic, especially when patient need surgical intervention? My third question regarding, you just mentioned about shunt. We do use the term palliative shunt, but in my opinion, shunt is also for symptomatic treatment, as good as doing a craniotomy. Again, craniotomy is for symptomatic, it's not to cure the patient. Why do we use the word palliative, but not for VP shunt, but not in craniotomy? Do you think that we are using the right term for those patients? My last question, Professor. We do use steroid a lot for metastatic patient, and how do we decide the balance? What is the limiting dose which are benefiting for the patient, especially in terms of palliative care? Because if excessive steroid may be more harmful than not giving steroid. What's your opinion regarding this? Thank you, Professor.
Oh, a lot of questions. So, come from the last one, shunt versus craniectomy. I think that the craniectomy could change life quality, and I don't think could be so useful for the rest, for the quality of life. That's why we just choose the shunt. And about the preoperative SRS, we just choose, now we are using it only not in patients with max 3 metastases, okay? And for between 3 and 5 centimeters. These are our parameters right now, because we are making a study. So I think we will use it for much more lesions and much more bigger lesion maybe. But now we use it just in this kind of patients. And really, I don't remember the first question. So sorry.
First question on the KPS, use of KPS to determine.
The use of KPS. Oh, yeah, I'm right. I do agree with you. But you know, the use of KPS is why we still use this one, this kind of evaluation, because it's the one used by the oncologists. You know, the oncologists, the first things they say you is, oh, it's a great KPS. But then you find that maybe they have a 70 KPS, okay? But you have cardiologic problems, every kind of problems that can access surgery. So I know, I do agree with you, but I have to just begin with that one. It's just the beginning, but it's not my goal. I do understand. I do agree with you. Yeah.
And
It's
last
just
on
a common language that that can can join every kind of specialist. That's why.
and the last on dose
Oh,
optimal
the dose.
for DEXA.
Actually, I don't do SRS, so I really don't know the dose. Sorry, I just
no.
no.
I mean the steroid.
Oh, the
Steroid.
steroid.
How
Oh,
do you
okay,
decide?
okay. I always try to remove the steroid. Always, just even one, just good, just one. But I always try to remove it. You know, when you collaborate with the oncologist, if the oncologist read the MRI and say, oh, there's a little bit of edema, let's start the corticosteroid. No, I really don't use them if you are not symptomatic. And if I find a patient asymptomatic or just symptomatic just a little bit, I always try to remove it, because really I know that you know, as a surgeon, if you use corticosteroid for a long time, the parenchyma is different. It's not a good thing for the patient, for the surgeon, and for everything. But I try to remove it. So sometimes the patients stay good with just 1 milligram, and it can't stay without it. But I think I try to use the less dose that is tolerated, because I really don't love it.
Thank you very much, Professor.
Yeah. Welcome.
Thank you very much. It was a really wonderful talk. We would hear the last concluding remarks from our chair, Professor Mukasa.
Oh, so thank you very much for your very excellent talk and then outstanding lecture. So sharing your expertise with us. So thank you again. So with this, I would like to conclude this session, first session. So thank you very much.
Well, thank you. Thank you very much, Prof. Casali and Prof. Akitake Mukasa, for this wonderful session. We had a wonderful discussion that followed, covering most of the questions. There weren't any left for me. So I would like to move on to the second session. Before that, I would like to mention that this has been broadcasted on WeChat, YouTube, and Zoom. And as of now, we have around 460 people who have logged in through all the different channels. Thanks to Professor Shubin for that. I would hand this podium over to our second chair, Professor Amit Thapa, to move ahead the session.
Thank you, Professor Raja. And at the outset, let me thank ACNS, Professor Yoko Kato, and the whole team of ACNS to be organizing such a wonderful webinar. It is really an educational one and an experience to attend. And today we have a very experienced neurosurgeon with us, Chao, who is the Deputy Chief Physician from the Neurosurgery Department of Peking University Third Hospital. He is also the Deputy Head of the Spinal Cord and Minimal Invasive Specialty and Deputy Head of the Neuroregulation Specialty. And his clinical research is much more on intelligent minimal invasive techniques in neurosurgery, spinal cord, and spinal nerve surgery. And he is one of the few neurosurgeons in China who have completed 6S and BCI's neuroregulation technologies. And without any further ado, I would like to invite Professor Chao for his deliberation on application of neuroregulation techniques in the reconstruction of neural function after neural injury, experiences from Peking University Third Hospital. Over to you, Dr. Chao.
Dear President, host, and all colleagues present online, good evening. My name is Wu Chao. I'm from the Neurosurgery Department of Peking University Third Hospital. I'm very honored to be invited to participate in the ACNS webinar. Today, I will introduce some clinical experiences of Peking University Third Hospital in the field of neuroregulation for treating nerve injury. As we all know, various neurological disorders such as trauma, stroke, and tumor can all cause nerve damage. And in the area of neurosurgery treatment, there are predicaments. First, due to the poor ability of neural regeneration, and the treatment and the rehabilitation process is lengthy. Due to the resulting physical movement disorders, pain, and other disorders, the patients have become incapacitated, and it causes heavy social and family burdens. And the traditional drug treatments and rehabilitation methods have shown poor results. The Peking University Third Hospital Neurosurgery Department is one of the most comprehensive spinal surgery centers in China for diagnosis and treatment. And the hospital established the spinal cord function reconstruction and rehabilitation center of PUTH, Neuroregulation National Engineering Research Center, PUTH Branch Center, and the BCI and the Neuroregulation Center. The MDT team include about 10 departments. Our team has have a complicated DBS, SCS, VNS, PNS, SNS, IDDS, and BCR for the neuro injury, and completing the piece of the puzzle for neural function rehabilitation and reconstruction. The first, SCS. This is the works that our team has already carried out. The most was neuropathic pain, and the effect of spinal cord electronic SCS in treating muscle tone disorders after spinal cord injury is ideal. And SCS surgical processes is not complex. And this is a clinical case. Spinal cord injury without fracture or dislocation of the cervical specific paralysis. This is a 50-year-old man, spinal cord injury of type without fracture of the cervical injury. Complicated paraplegia below the umbilicus, continuous spasticity of lower limbs, and is a cervical spinal cord injury, specific paraplegia. We completed the SCS testing during SCS intraoperative ECG monitoring showing positive correlation. Post-operatively, the muscle tone of both lower limbs decreased and spasticity was significantly relieved. And another case, 40-year man caused by a car accident, T12 fracture occurred. Emergency spinal internal fixation surgery was performed. Post-operatively, complete paraplegia at the T12 level was observed, including complete paralysis below the umbilicus and incontinence of both urination and defecation. Post-operatively, the ECG detected a positive correlation between the spinal cord, the SCS partners, and the EMG. The rehabilitation is underway. IDDS was used to treat the muscle hyperactivity and the pain after a spinal cord injury. This is a 63-year man, specifically of the lower lips after thoracic vertebral injury for 3 years. Modified adverse skills 4, VAS 7, and IDDS with baclofen was implantation. And the post-operation modified adverse skill was 2, VS was 1. And this is the drug dose about evolved testing phase and the initial dose after implantation. For adults, the general starting dose is 100 day to 300 day per day. And this is a clinical case. It's a 40. This is another clinical case. Is a 56-year female. Post-operative pain in the sacroiliac region and the lower extremities after sacrosarcoma surgery, and even high-dose drugs were used. The VAS was 10, and IDDS with morphine was implanted, and the post-operative VS were 2. ACNS in our department, ACNS was used to treat neurogenic lower urinary tract dysfunction. The most common urinary dysfunction in neurosurgery is NLUDTD. In the past, neurogenic bladder was commonly used to describe this condition, but it's now clear that the lesion is not limited to the bladder alone. Lower urinary tract dysfunction is closely related to neurosurgery disease. Central nervous system disease are a major cause of lower urinary tract dysfunction. Among them, spinal cord and spinal column disease are particularly significant in causing a lower urinary tract dysfunction. The overall proportion of patients with neurogenic lower urinary tract dysfunction is as high as 70 to 84%, and the incidence rate of patients with injury above the sacral level is about 90%. And the ultimate goal is to protect the function of the upper urinary tract, restore or partly restore the function of the lower urinary tract, improve urinary incontinence, and thereby enhance the quality of life of the patients. About the section of patients for ACNS treat of NLUTD, it should clear diagnose of the disease, detailed screening, tumors, stones, prostatic hyperplasia should be excluded. No improvement after systematic conservative treatment. A mental symptom are controlled. There is a willingness to be treated, and the economic capacity permits a certain level of connective ability. This is our department's clinical outcome. SM can bring more comprehensive benefits to patients with NLUTD. 152 months follow-up study on 17 patients with NLUTD and all intestinal dysfunction who had ACNS implanted revealed that first, for NLUTD patients with urinary and fecal problems, the improvements in intestinal function tends to be better than that of urinary function. Their WS score decreased from 13.5 before treatment to 2.5 with a significant effect. Although the sample size was small, ACNS has been preliminary affirmed in controlling intestinal symptoms for NLUTD patients. The VS in our hospital was used to treatment the patient with upper lip dysfunction after ischemic stroke. The clinical trial was started in 2025 in our hospital, and the peripheral is here. PS was used to treatment the peripheral nerve injury, especially for the patient with pain. This is a clinical case. It's a 56-year female. It is a CPN injury. Left knee injury resulted in a foot drop and progressive lower limb pain and hyperasthesia for 6 months, and the VS was 8. Neuroedema was quite obvious in MR and ultrasound. First, I performed nerve decompression and epineural repair, and then implanted the stimulating electrode under the assistance of an endoscope. This is the stimulating electrode under the assistance of an endoscope. Okay, it's the overall drawing. Electrical stimulation cycle is 2 weeks. After 2 weeks, the PNS was removed. Frequency was 20 to 30. Width was 50. Intensity 0.5 to 1.5. Duration 3 times a day for 30 minutes each time. When the PNS turned on, VS was 1 to 2. When PNS turned off, VS was 6 to 7. Within 3 months after the surgery, the foot drop has improved significantly. And the last BCI. 2025, we launched the multi-center clinical trial of the NEO brain-computer interface. And at the same time, we established BCI in the neuroregulation world. This is one of the. This is a clinical case. It's a 32-year man, quadriplegia after a traffic accident for 6 years, and a post-operative cervical posterior disc compression surgery. Injury level was cervical 5, and the grade of injury grade was ASA 2. This is a technical diagram. It contains a signal collector, wireless communication, translation, and action execution. The BCI involves implantable neural acquisition and stimulation device, and implantable cathedral electrode case, and a closed loop brain neural signal processor, and a one-time surgical kit. This is the clinical case surgical procedure. First, we based on robot navigation, outline body surface landmarks, and precise craniotomy. After precise craniotomy, anatomical rectification of the target function area was implemented, and then electrophysiological rectification of the targeted function area was implemented, and we fitted epidural collection electrode. And last, we implementation of the signal acquisition system, and it's the overall drawing. Three days after operation, we signal rectification was implemented again. And after 6 months, 6 months after the operation, you can see the hand. The hand function was well. Take-home message: neuroregulation therapy for functional disorders after neuro injury requires the collective participation of rehabilitation departments, neurology departments, electrophysiological teams, medical engineering teams, and neurosurgical departments. Neurocircuit remodeling is the neurophysiological basis for the effective improvements of function through neuroregulation and intensified rehabilitation training after neurosurgery. In neural injury, parameter optimization requires further clinical trials for rectification. And the ethical issues of invasive interventions measures still need to be overcome. The contents fair today is rather scattered, and some of it pertains to clinical research. For details discussion, you can chat me via email to have a more in-depth consideration. Thank you for attention. Thank you.
Chao, for a wonderful presentation. You actually walked us through the different modalities of stimulation, be it DPS or spinal cord stimulation, VNS, SNS, and baclofen pump and peripheral nerve stimulator. And then you concluded with an implantable BCI device, and you showed the procedure, how it is being done at your place. A wonderful presentation and good case reports for each of us. Well, I didn't see any question coming up, but then I have few questions to you. The first is regarding your protocol on when do you offer these devices to your patient. The second is what is your training protocol? Because all these patients need to be trained on these devices. So what is a training protocol?
Okay, the clinical test was used to improve the hand movement. So it's a clinical test, a clinical trial.
I think we can close if it's okay.
I'm sorry.
That's fine.
No issues. Yeah.
Fine. Thank you, Prof. Any concluding remarks, Prof. Thapa?
Yeah, so it was wonderful presentation, and in fact, there is a lot of role of. I think this particular branch of neurosciences should be called as restorative neuroscience. In fact, it has come up in a long way, in a big way, both as a function neurosurgery as well as for the restoration of function. And as Dr. Chao put it up in his presentation, he showed it how it can be used for managing pain, spasticity, improve the bladder function as well as the intestinal functions, power of the limb, and also it has now replaced the whole limb after getting amputated or any injuries where the limb is non-functional. So there's a lot of interest, growing interest in how this brain-computer interface can be used for the full potential. And as Dr. Chao put up, that we have that most of the institutes in China has actually started clinical protocols besides being research. So we are very much interested to look forward to what the outcome of these researches are, and then as soon as they can come into the clinical practices. So with this word, I would like to conclude this session, and of course, a big thanks to both Professor Raja and Professor Liu for managing this session, and thanks to the whole ACNS team. Thank you once again.
Well, thank you very much. We are indeed indebted to you for your kind support for the ACNS webinars. With that, I will close this officially now. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to thank both the speakers of today, Professor Cecilia Casali and Prof. Chao, as well as the chairs, Prof. Akitake Mukasa and Professor Amit Thapa for the time and support for the ACNS webinars. Special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel. And as I mentioned earlier, we have around 460 people who have logged in through WeChat, YouTube and Zoom. A special thanks to my co-host Liu Bun Seng for joining me today. So until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.